The cubital, antecubital fossa, is a triangular-shaped depression over the anterior aspect of the elbow joint. It represents an area of transition between the anatomical arm and the forearm, and conveys several important structures between these two areas. In this article, we shall look at the anatomy of the cubital fossa, its borders, contents, and clinical relevance. The cubital fossa is triangular in shape and consists of three borders, a roof and a floor. The lateral border is the medial border of the brachioradialis muscle. The medial border is the lateral border of the pronator teres muscle, and the superior border is a horizontal line drawn between the epicondyles of the humerus. The roof is made up of the bicipital aponeurosis fascia, subcutaneous fat, and skin, while the floor is composed of the brachialis muscle proximally and the supinator muscle distally. The cubital fossa serves as a passageway for structures to pass between the upper arm and forearm. Its contents from lateral to medial include the radial nerve, which travels along the lateral border of the cubital fossa and divides into superficial and deep branches. The radial nerve has a motor and sensory function in the posterior forearm and hand. The biceps tendon passes centrally through the cubital fossa and attaches to the radial tuberosity, giving rise to the bicipital aponeurosis. The brachial artery bifurcates into the radial and ulnar arteries at the apex of the cubital fossa, and the brachial pulse can be felt in this area. The median nerve travels medially through the cubital fossa and has a motor and sensory function in the anterior forearm and hand. The roof of the cubital fossa also contains several superficial veins, including the median cubital vein, which connects the basilic and cephalic veins and is commonly used for venipuncture. In terms of clinical relevance, a supracondylar fracture, which is a fracture of the distal humerus, can affect the contents of the cubital fossa. This type of fracture is typically caused by falling on an outstretched hand and is more common in children. Damage to the brachial artery can lead to Volkmann's ischemic contracture, causing uncontrolled flexion of the hand. Other nerves, such as the anterior interosseous nerve, ulnar nerve, or radial nerve, can also be damaged. The Gartland classification is used to categorize these fractures, with type 1 being minimally displaced, type 2 being displaced with an intact posterior cortex, and type 3 being completely off-ended. Treatment options vary depending on the type of fracture. And that concludes our discussion on the cubital fossa. Thank you for watching.